Thank you. Good morning, ladies and gentlemen. I'm Cheng Hsiao from Taiwan. Many thanks for giving me the opportunity to share my topic here. It's my pleasure to present our study investigating subsidence in cervical disc arthroplasty with blind disc, a retrospective analysis conducted at TCVGH in Taiwan. Here's the outline of my presentation. It's divided into 4 parts: introduction, material and method, result, and the discussion. The first part is the introduction. Since the U.S. Food and Drug Administration approved cervical disc replacement in 2004, cervical arthroplasty has become the most common non-fusion surgery for cervical diseases. However, as follow-up period gets longer, more complications are showing up, like heterotopic ossification, osteolysis, and dislocation. This has been widely discussed in recent years. Today, I'm focusing on infant subsidence, which has been less discussed in the previous literature. Now let's move on to the second part, the material and method we use in this study. This is a study of a single institution, a single neurosurgeon, using a single blade of blind disc over an 11 years period. We collected data from 125 cases of 1 or 2 level CDA surgeries, and in total we analyzed 180 blind discs. However, we excluded 21 patients because they didn't meet our inclusion criteria. In the end, we included 104 patients in the study. 55 were 1 level and 49 were 2 level surgeries. We define infant subsidence as a reduction of the functional spinal unit height, FSUH, greater than or equal to 3 mm after surgery. We also established a grading system for the subsidence of prosthetic disc. When the FSUH decreases but is less than 3 mm, it's classified as grade 0, which means no subsidence. When it decreases by more than 3 mm but less than 6 mm, it's classified as grade 1, mild subsidence. When it decreases by more than 3 mm when it decreases more than 6 mm, it's grade 2, moderate subsidence. And when the implant further loses its function, it's classified as grade 3, severe subsidence. Now let's move on to the next part, the result. Our findings reveal that 18%, accounting for 70% of the total cases, experienced implant subsidence during the follow-up period. Out of the 153 implant blind discs, 35 cases, about 23%, showed implant subsidence. Among these, nearly 80% were classified as grade 1, around 20% as grade 2, and only 6% as grade 3 subsidence. This table compares the difference between the 2 groups, those with subsidence and those without. The significant difference between the 2 groups are the preoperative mean disc height, as well as the changes and ratios in disc height before and after surgery. However, when these 3 variables were included in the logistic regression analysis for implant subsidence, only the preoperative mean disc height was found to have statistical significance in the multiple regression analysis. The preoperative mean disc height is calculated as the average of 3 heights measured at the anterior, middle, and posterior intervertebral disc. Furthermore, the cutoff value for the preoperative mean disc height was 4.48 mm. That is a preoperative mean disc height of less than 4.48 millimeter is a risk factor for implant subsidence. And finally, we'll end with the discussion part. In the discussion, we go over some potential risk factors for implant subsidence, such as osteoporosis, undersized haunted footprint, implant oversizing, and implant preparation. In this study, we routine test bone mineral density, BND, for all women over 50 and men over 60. Patients with a T-score below negative 2.5 were not eligible for cervical disc arthroplasty surgery. When we analyze the BND and T-score for these patients, the results show no difference between the two groups. For the implant contact footprint, we use the anterior posterior ratio multiplied by the lateral ratio for our analysis. However, the results show no difference between the two groups. Regarding implant oversizing, since the blind disc has a fixed height of 8.5 millimeter, we found the incidence of implant subsidence was higher in patients with a preoperative mean disc height of less than around 4.5 millimeter. So our study concluded that oversized prosthetic disc causing an increasing of more than 4 millimeter in the preoperative mean disc height were linked to a higher rate of implant subsidence. The subsidence rate in this study was higher than previous studies. We think it might be the excessive implant preparation needed for the blind disc. However, since we only look at the blind disc, we'll need to compare it with other prosthetic discs to get clearer answers. In this study, we show that the subsidence rate went up when oversized prosthetic discs were used, increasing the preoperative mean disc height by more than 4 millimeters. This rate was also higher compared to previous studies, likely because too much implant preparation or overall distraction during the placement of the blind disc. These days, new prosthetic discs require less implant preparation and offer more size options, but choosing the right size for each patient is still important. In the future, we should focus on adding more size options and reducing the minimum size for better fit patients with narrower disc space. This is the end of my presentation. Thanks for your attention.